Good evening, everyone, and welcome to tonight's Women Leading Philanthropy event. My name is Erin Eccleston, and I am the chair of the board of directors of the University Hospital Foundation. As we gather here today, I would like to acknowledge that we are gathering on Treaty 6 territory and the homeland of the Dakota, Lakota, and Métis. We also recognize that the areas where we gather and where we work are historical gathering places for many other Indigenous peoples. Recognizing this history is important to our future and to our efforts to close the gap in health outcomes between Indigenous and non-Indigenous peoples by knowing what the land and the traditional people of that land offer us. So on behalf of the RUH Foundation, I want to sincerely thank you for being with us this evening. Your presence and your generosity continue to drive groundbreaking advancements in healthcare for women and their families across our province. WLP, it's about impact. It's about creating a space for women's voices, for leadership, and for innovation to flourish in healthcare. Together, we've built something truly powerful. Since launching in 2018, Women Leading Philanthropy donors have raised over $1 million. Proof of the powerful change that happens when generous hearts invest in bold ideas. Together, you have championed the vision and innovation of women healthcare professionals across Saskatchewan, awarding $700,000 in grants at 7 WLP meetings and contributing more than $300,000 to projects that resonated personally. That is real, that is lasting change for healthcare in Saskatchewan. And it all started with you. So this evening, I'm very pleased to introduce Sharon McDonald, a donor and former RUH board member. She'll talk about her longtime support of the foundation, her personal healthcare journey, and the impact of the research being done through WLP. Welcome, Sharon.
Good evening, everyone, and thank you for your membership in RUH Foundation Women Leading Philanthropy. And thanks as well to RUH Foundation for inviting me to share my story tonight. I am pleased to be a founding member of Women Leading Philanthropy, and my relationship with RUH Foundation goes back much farther, all the way back to 2001. I was invited to be a member of the RUH Gala Ball Committee. The RUH Gala Ball was the event in the fall gala season in Saskatoon. We had a unique theme each year, and guests were thrilled to step into the transformed Besborough Ballroom. I'm proud to mention the 2001 RUH Galaxy Ball won a national award, the Association of Healthcare Philanthropy Best Special Event of the Year in 2001. In addition, the RUH Foundation Gala Ball Committee chairs and co-chairs were honored with a National Philanthropy Award, and I served as chair or co-chair in 2006, 7, and 8. As a passionate volunteer, I believe everyone can and should find some way to give back to the community. My next logical step was to apply for a board position with RUH Foundation. I served 2 years on subcommittees and 3 full terms for a total of 8 years volunteering with RUH Foundation Board, ending in June of 22. During my board tenure, the idea of a women's club or committee to support women's healthcare was put forth, unanimously supported, and funded by RUH Foundation initially. RUH Foundation Women Leading Philanthropy. What a success. Over the past years, WLP has received 33 proposals from brilliant physicians, scientists, and healthcare providers. WLP, as Erin has mentioned, has granted $700,000 in annual grants and an additional $300,000 in anonymous donations. As WLP members, we vote, and it's hard to choose. Although not all presenters win the 100,000 check, we are all winners through research funded by Women Leading Philanthropy. As a layperson, it's exciting to hear these women speak passionately about their projects and such a variety of topics, resulting in impact for women's health in Saskatoon, Saskatchewan, and beyond. I happen to know a number of presenters and grant recipients, personally or professionally. Dr. Gudrun Kasper-Bell, co-recipient in 2024, along with Dr. Mina Niazi, for diagnosis and treatment of osteoporosis in women with liver disease. Dr. Jen Brown-Broderick, HPV self-sampling for primary cervical cancer screening in underserved women in Saskatchewan. Dr. Sarah Donkers, Hope in MS, promoting functional neurorecovery. And Dr. Meeta Manna, Mainstream Genetic Testing Pilot Program 2023. And Dr. Manna is my oncologist. I am a breast cancer survivor. This Saturday, June 7th, 2025, is the 3-year anniversary of my diagnosis with aggressive but treatable breast cancer. Devastating news. I was healthy, fit, an athlete, volunteer, I have a family, and I had a demanding, successful career. How could I be the one in 8 diagnosed with breast cancer in their lifetime? In 2017, I completed the BC Ride to Conquer Cancer from Vancouver to Seattle to raise money for cancer research. 2 days and a 250-kilometer bike ride while thinking of my friend, Chris Gordon, there you go, and her husband, Bruce, who lost his battle with pancreatic cancer. Chris is a member of the WLP committee and has done an amazing job at that, and as well for raising awareness and funding for pancreatic cancer research at the University of Saskatchewan. At my initial meeting with Dr. Manna, as she laid out the extensive treatment plan, I asked her if I would have a normal lifespan. What a question. Dr. Manna told me I had to have hope. She didn't say yes or no. She just said have hope. And hope is what we can give other women by funding research projects through Women Leading Philanthropy. My breast cancer treatment plan: first, shave your head, which wasn't terrible once I did it. I felt fierce and strong with no hair and a lot of hats. A lot of hats. I had 16 chemotherapy treatments in 19 weeks. Bilateral mastectomy and immediate reconstruction, and surgery was the easiest part of all the treatments. 17 Herceptin infusions, a relatively recent miracle drug. Zometa infusions for 3 years. Preventative drugs, neratinib, also known as Nerlinx, daily for 1 year, the worst drug, and $9,000 a month. Good thing it was paid for by my husband's insurance, because otherwise you're out of luck. No, it's the worst drug. And anastrozole, another preventative drug, daily until 2030. Altogether, including physician appointments, blood work, treatments, I had 200 plus medical appointments or procedures. Although the research projects and winning grants for WLP did not impact my diagnosis specifically, I know I benefited from prior researchers working to find more effective, less invasive treatments, and maybe someday breast cancer will be a less devastating chronic disease. My treatment plan was intense. But I knew and I hoped that with the miracle of science, an amazing medical team, and my own willingness to do whatever it takes to become healthy, I would get to the other side And here I am. And here's my endocrinologist. I need a hug. Here I am. Still at risk for recurrence, but living a relatively normal life. And on December 4th, after over 900 days in her care and in the care of the Saskatchewan Cancer Agency, 200 plus treatments, and the passing of both of my parents during my treatment time, Dr. Mana, or I call her Mita because we cycle together, Mita fired me. She fired me. She said, "You don't need me anymore. I'm dismissing you." And I went, "What?" Joyous and frightening at the same time. I was on my way that day to play my first pickleball game, and Dr. Mana warned me that pickleball is one of the highest injury sports. But here I am, injury-free. So my call to action is to invite a friend to Women Leading Philanthropy. Is there a more inspiring, more important event to attend with a sister, your mother, a daughter, or a friend? Thank you from the bottom of my heart to my amazing medical team, Dr. Mita Mana, oncologist, Dr. Pam Myers, breast surgeon, Dr. Geethan Chandran, reconstructive surgeon, Dr. Beata Scoop, anesthetist, all the chemo nurses, amazing, and Dr. Henny Reese, pathologist, and my partner for the BC Ride to Conquer Cancer in 2017. Along with her daughter, we completed the 250 kilometers, each of us. And Dr. Reese is now facing her own cancer battle. Thank you for supporting brilliant women physicians, scientists, and healthcare professionals who improve your health, help someone you know, or someone you will never meet. Please invite a friend to join RUH Foundation Women Leading Philanthropy, and let's spread hope. Thank you. Thank you.
Thank you, Sharon. Thank you for sharing that deeply, deeply personal story.
Probably crying.
You show us just how meaningful the work of Women Leading Philanthropy truly is. So now, please join me in welcoming our dynamic co-chairs to the stage, Dr. Mary Kinloch, WLP Program Chair, and Megan Dubois, Honorary Chair and Board Member of the RUH Foundation.
Thank you so much, Sharon. Where are you? There you are. Thank you, Sharon. Thank you for sharing that inspirational story. And as we spoke before, I can't imagine when you must have joined Women Leading Philanthropy as one of the inaugural members and you thought, no, I'm going to be here to help and volunteer. And I really took away from your story in saying that, yes, you're resting on the research from before, but the work that you're doing here and supporting, and that everybody in this room is supporting other women with breast cancer in our province right now.
Yeah, absolutely. Mm-hmm. Absolutely. You never know.
Yeah, thank you so
Don't take
much.
it for granted, good health.
Yeah, thank you.
Thank you for the invitation.
So most of you I have met before, and thank you for all the people rejoining us again for Women Leading Philanthropy. And my name is Mary Kinloch. I'm a pathologist in Saskatoon City Hospital, and I think we've all had an incredible journey watching Women Leading Philanthropy grow in our city and the impact that it makes. Sometimes it's so hard to be in public health care, and I really look forward to coming to join with you 3 times a year to be the motivation to keep going in between those meetings, because it truly is transformational what we've seen from the leaders of our winning projects that have been able to get things moving in a way that we just haven't seen otherwise. It really has been something that we look forward to for strength and resilience in the time in between the meetings.
Thank you, Mary, and I echo the feeling in this room is beautiful, and I was sad to have to miss the February meeting or the January meeting, and I heard wonderful things. It was such an engaged audience and group of women here, and again, thank you, Sharon, so much for sharing your story. It was very, very meaningful. So I do want to take a moment also to express our gratitude to the incredible sponsors who helped make this evening possible, and I know many of you are in the room with us here this evening. So our thanks to AstraZeneca, IG Wealth Management, MNP, Merck, Bayer, SO Asher, and our many gift and kind supporters. Let's give them a round of applause. We're truly so appreciative of your support and your commitment to improving women's healthcare in Saskatchewan. And so I think now we're going to transition over to an update on the project. And first, before we do that, and I know that so many of you are excited here also to hear this update, and we have both of them in the room this evening, which is just super exciting. Let's first listen to. Okay, I'm going to step back. I'm going to start again here. So last September, many of you were probably there. We selected a powerful, forward-looking project to receive WLP's $100,000 grant. Early diagnosis and treatment of osteoporosis in women with chronic liver disease, led by Drs. Mina Niatsi and Drs. Gudrun Kasper-Bell, who are here with us this evening. So first, we're going to take a moment to revisit the original video and hear what inspired their vision that captured your votes.
Hi, my name is Mina Niazi, and I am a gastroenterologist and hepatologist at the Royal University Hospital. My other title is Clinical Assistant Professor within the College of Medicine at the University of Saskatchewan. As the clinical lead for liver transplant program in the province, I've witnessed countless women suffer debilitating complications related to osteoporosis. And therefore, our project under the title of Early Diagnosis and Treatment of Osteoporosis is very close to my heart, as I've seen my patients suffer. So you may ask, why do we care? Currently in Saskatchewan, my patients wait minimum 10 to 12 months to get a bone densitometry test, which is a diagnostic image to determine if somebody has osteoporosis. With the current pilot project, we're proposing to purchase a device which will allow myself and my colleagues in the clinic to diagnose osteoporosis on the spot. Our hope is in a multidisciplinary setting to be able to offer the test on the spot during the initial visit, and more importantly, to be able to initiate treatment during the same visit. And this will ultimately shorten the wait time from years to months and potentially down the road to weeks.
My name is Dr. Kasper-Bell, and I'm a tenured associate professor of the University of Saskatchewan. I'm working as an endocrinologist. With our new project and a new machine, the EchoLite, that is an ultrasound machine that can do a very precise bone density, we can have a bedside tool with the results right away after scanning, with no radiation, no further health risk. We can decide on the future plan, discuss it with the patient. So with our model, hepatologist and endocrinologist seeing the patient at one appointment, doing a bone scan, finding the results, and come up with a treatment plan, we are very time and cost efficient, not only for our female population in Saskatchewan, but also for our healthcare system. With our project, we will have a positive impact on bone health in women in Saskatchewan.
Hi, my name is Crystal Graham. I'm 40 years old and a liver transplant patient from Saskatchewan. I was diagnosed with a rare liver disease at the age of 9, and at the age of 24 had my first liver transplant. The transplant was definitely a very challenging time in my life. After transplant, I got put on steroids for about a year, pretty high doses, and had to wait a little over a year for my first bone density. Eventually got the bone density scan done and got diagnosed with osteoporosis. With that diagnosis, they also found that my back was fractured in 2 spots. I am 2.5 years post-transplant and currently still waiting for a repeat bone density scan. A couple of months ago, I had a CT scan done and they ended up finding a newer fracture in my back. By having the Echolight station at bedside, it would give you some peace of mind knowing what's going on with your body and if something needs to be treated for it.
Our bones are an important structure in our body, and you can think about it as the foundation of your home. Our bones become brittle and weak. We're prone to falls due to imbalance and acquiring fracture. In women over the age of 50, 50% of them will have osteoporosis. And unfortunately, they may not know about the diagnosis and only learn about it after a fracture. After a fracture, and often hip fracture, 40% of women are not able to walk independently, and over 80% may not be able to carry on with their activity of daily living, such as grocery shopping, bathing, shower, and the ability to look after their children. Our goal with this tool to change the landscape how we treat osteoporosis at the Royal University Hospital. This will be an innovative way to approach treatment, and we could be setting the stage to change practice not only in the province but nationwide.
Please join me now up onto stage, our winners of the WLP 2024 project, Dr. Casper Bell and Dr. Mina Niazi. Yes, make the person with the knee brace walk the furthest, yeah.
Mic check.
Mic check.
Yeah. All good.
All right. So, first of all, congratulations again on reaching this exciting milestone. I know that when I was counting back, it always feels like the time went by so fast, but I know there's been a lot happening. I want to start by asking you, Dr. Niazi, can you tell us, there's been something else, another milestone happened in your life. If you want to share with us what has recently happened for you. Spoiler alert.
Yes, some of you may know. So actually, just when we won the I'm struggling with my word, the award.
Yeah.
I was I still wasn't sure, but we found out that we were expecting. So on May 8th, I welcomed a baby boy, Gabriel. 3 weeks ago. 2 weeks or 2 days now, and it has been definitely an adjustment, but a big change. So yeah, thank you for all the emails and congratulations that I've received from the office.
Amazing. Well, if you haven't done the math already, that was 3 weeks, like you said, ago. And so that means that, that it's just incredible that you're able to share with us today what's been going on. I know that you're also Saskatchewan's only full-time hepatologist, so I want to know what that's going to look like in the next no pressure.
Yeah, I've been getting that question. I'm passionate about work, so balancing personal and professional life will be an adjustment and learning experience for myself and our family. I intend to actually return back to work within the next few months, partly because we haven't been able to identify a locum who could cover for me at the moment. But I would like to attend to our child as well, so probably working slightly less than I'm used to.
Absolutely. And this is your first outing, I hear, so we're really lucky.
Yes, this is actually very nice. Many actually volunteered to look after him here, but I said, you know what, I could use this opportunity to socialize than attend to the babies.
Incredible.
So as we heard in our January update that the Echolight device is here, so can we count on then
Dr. Casper Bell
You sure can.
to
So the Ecolite system arrived complete in the last week of April. So it is ready to go. I was supposed to go with the machine to Thunder Bay for training. I had a little incident happening to myself when I attended a conference. I was dancing and yeah. So that happened. So I was a little bit immobile. Then the day the machine was delivered, I had to go downstairs and pick it up. So my mobility was kind of back. Otherwise, it would be still in the basement. So this is in my office, and I'm going to training in the next 2 weeks. That is a process. So I'm familiar with the machine, but I would like to make this complete by screening different kind of patients. So it has something to do with, for example, the BMI, how to adjust that. Because you know, when people are on steroid medication, they unfortunately have a different kind of body mass index than people without steroids. And the fatty distribution is a little different. So we are talking more about truncal obesity while we are doing the ultrasound on the vertebrae and on the femoral neck. That is a challenge, of course, then in those patients. Then, of course, we have to look at patients who have already had kind of fractures due to osteoporosis. Then the approach is also a little bit different. So that is what I'm gonna look into a little bit more. And then we can start. We have a long list of patients that are ready to go. We, of course, have our patient clientele that we are going to work with. Those are the ones with liver disease. But we also going to have a group with people, non-liver disease patients. And we decided that we're going to screen one after one all the members of the organization. So that means that you're going to get a bone density, and like we said in our video, it's not just the bone density, it's also the quality of the bone, because you can have good bone density, but the bone is not good. Why is that? Yeah, because of medications, sometimes because lack of exercise, the way it's structured, genetics play a role. So you're going to get a very objective measurement, and then your family physician, or when you're seeing already a rheumatologist, can then maybe decide on the treatment or change the treatment. So we are very excited to start it. The beauty of that scan is basically that it doesn't have side effects. So the radiation component is not there. When we look at our everyday life, we are exposed to radiation even when we go on a trip to Calgary, a short flight. Did you know that flight attendants are only allowed to work 75 hours in the air because of the radiation? So a full-time job that normally means 40 hours a week, they cannot fulfill in the air because of the radiation exposure. So whenever we fly to business meeting for fun or whatever, we are exposed. So for a medical screen, a screen, not a therapy, I would prefer a not challenging method so that the risk is very low.
So I think ultimately we should be able to offer the test within the next month, from what I'm hearing. And yes, we do have a long wait list, and we're excited to enroll patients. So we would start with our liver patients. And again, as my colleagues and even Dr. Mita Mana's comment you may remember from January meeting, that there is room for collaboration. Many of patients with cancer diagnosis actually are at risk of osteoporosis. So I could see the opportunity to network with colleagues in other disciplines as well. So I've had colleagues, including Dr. Mita Mana, approached me how we could collaborate so we can offer this even at Cancer Center in addition to our clinic. So it's exciting. And yes, I'm definitely staying on the project. But Dr. Casper Bell kindly has agreed to lead while I'm slowing down a little bit for the next few months.
Thank you. For someone that isn't familiar with the Echolate, how big is it and how complicated is this machine?
So I could have brought it with me. It is in a suitcase, but has a little bit of weight. Okay. So when you look at a regular, it's a little bit more than a check-in bag, and it is an ultrasound machine. So it is like a compact machine, like a disc player with a monitor, and you can, like a laptop, flip it up, and you have a probe, like an ultrasound probe, and that is how you're gonna do the examination.
Okay.
It's nothing else like an ultrasound, huh? And you saw that on the video.
Yeah.
I think that that's the first time that we've heard that the femoral and the vertebrae are going to be tested. And does it take like about 10 minutes or?
So it depends on the positioning. So the very good, why I'm so into that kind of examination, it is artificial intelligence driven. So the normal scans up to date are, so to speak, interpreted by the radiologist or nuclear medicine person. So we have a lot of factors that can vary the results. For example, the positioning of the patient in the machine. Is the patient still or not still? Is it a little bit crooked or not crooked? So that depends on the nuclear medicine tech, on the patient. Then the picture is coming. The picture is, so to speak, a standing picture that is sent on a screen to the interpreter. And you can see a lot of different ways to interpret it. You can see artifacts. You don't know whether the patient moved or whatever. So it is a lot of human error in that interpretation. Here, millions of pictures were screened in, meaning that when I do the ultrasound in the position in the first, for example, the first vertebra, L1, and the positioning of my probe is not 100% correct, it's not going to measure. Because there are too many yes, no, yes, no, yes, no, yes, no. So meaning, when you say it takes about 10 minutes, when I'm very clumsy and I don't get the right angle, it can take an hour. Because it will not let me finish that reading, may I call it reading, until I have the right position. And then I move on. So it is very promising that the variant or the mistake rate is very, very low.
Although with practice you will be perfect.
That's right. So the meaning of this is that we're going to get a very high yield result, and with that result there is no questioning anymore. Like what is I don't know if you ever had a bone density. When you look at the score is very open, so it's plus, minus, and there is like -2, -2.5. So where are you? So yeah, you're in between 2 and 3. Yeah, but is it closer to 2 or is it closer to 3? When do I have to start a more aggressive treatment? And like I said, that gives you the bone density, but doesn't tell you a thing about your quality. And here you have the density and the quality report, and that also can change your approach, what kind of medication you're going to choose for this patient in particular.
Just as a practical question, are you going to then, is it like a point of care test where you'll let the patient know right when they're in the room with you?
So since I'm the only endocrinologist in Canada who does bedside ultrasound, thyroid, I always show the patients exactly what I'm doing, what they see, to make them understand. What is this about? why am I so aggressive with my suggestion for treatment? And that is also going to help treatment planning, because a lot of times patients don't know, well, they heard so many bad things about this and this medication, side effects. Yeah, but in your case, you see it yourself. This is the only way to go. We're going to achieve much more understanding and compliance than when we just send them a letter or to let the family physician discuss then the results.
Okay, so I'm going to take your question, Mary, because I know you speak from the heart and come up with your own questions. If you're zooming out, what is your long-term vision for this technology? Do you see this something that can be scaled across Saskatchewan? Is it something that can be a game changer for detecting osteoporosis?
So it is already a game changer, and it is very established in Western Europe.
Okay.
Yeah? They started that in 2014, and that is a routine practice.
Okay.
Always takes a little bit, because ultrasound is, how can I say that? Ultrasound was not the driven thing here. Yeah. Now they start ultrasound, but they did other tests. Why is that? I don't know. So it's going to be the future method, because first of all, it's quick and very precise. You talk with the patient the result right at bedside. You can involve a colleague, like when we do the joint clinics. 2 specialists discuss that with the patient. So we can, so to speak, be more efficient, see more patients in a certain time frame, and reach out more, because we could also take that machine and go up north.
Right.
Mobile clinic.
Yeah, I could see that, especially if it's that small.
Correct. Suitcase.
And do you have to, is there funding that's required for the training? Is that a bit of a barrier in terms of the financial commitment?
No.
No,
That
you
is-
could
that
train
is
others
all-
to do it.
That is all in the package. Yeah?
So Mina, what are you hoping, like, so let's say Gabrielle turns 1. What are you hoping to see with your project when we're celebrating his first birthday?
I would like to complete our project, of course, and there will be an opportunity to share with our audience and donor the findings. We also would welcome to share the results with our patients. I think given that we are dealing with a novel equipment, it means that the findings will be worth disseminating, at a conference as well as research. Furthermore, I think this will serve as an opportunity to reach not only within the private sector, but we know that there are sometimes, private clinics who are starting to actually do ultrasounds and imaging, where they may be more appealed to actually offer it. So as a matter of fact, I think a few of the provinces such as Manitoba and Alberta have it already at a cost. But I think we're very lucky to be able to offer this through RUH, through the WLP and RUH Foundation funding, because we're setting a stage to demonstrate, the value of public sector, but also that we can, as Saskatchewan has been, throughout history, that we can change and transform healthcare. So it has meaningful clinical meaning, but also for our patients, especially female patients out there, that this is the way to go, and some of the benefits and the risks of what we have currently available has been highlighted, so I'm not going to take you through that.
But your patients must be excited. They must know that now it's here and they're waiting. And
Crystal Graham,
Yeah.
who also she has an update. She got married after the award ceremony we had. But yeah, she's been actually asking, and she's just among a few patients that are very excited to get on this. And While I'm away, I have a few tasks for my secretary. She actually has created the list of patients who've been waiting for bone density. So as soon as we're set up, we will be actually starting to book our patients.
That's
for this
great.
now.
Well, I can't wait to hear what the update is going to be when we rejoin together. That's going to be great.
I know that there is many curious and very engaged minds in the room, so I thought we could open it up to the floor to see if there's any questions as follow-ups to what has been discussed. While you're thinking of your question, I do have a quick follow-up to the AI comment. So that, what I heard was around precision and making sure that the diagnostics are accurate and that you're getting the picture right. Do you actually get a report? Like, is there a diagnostics report that is generated through the AI, or is that still very much human-led?
No. So we're going to get a printout, so to speak, a graph telling us exactly where we are with our bone.
Okay.
So we're going to get one from the vertebrae because there are 4 points. It's there 1, 2, 3, and 4 that we measure. And we're going to get a result for each single one. And then we're going to get a result for our femur head. And those together are going to be the result for your risk.
Okay. So it's completely AI driven, but you would obviously go over to make sure it seems accurate. There would be
That's
like
correct.
a human oversight.
It's the best kind.
Yeah.
Very cool. And
I recognize this is Women Leading Philanthropy, but will men be also able to get this tested?
That's, yeah, because that is very funny that you are asking me that. So maybe you have heard in the last, it is basically ever since a couple of years in the news that so many bodybuilders or wrestlers are dying of sudden death. That is because of all the doping. What are they using for doping? Mainly testosterone and steroids. So testosterone is in men the only hormone that is helping them to build up bones. So men who have low testosterone are also at risk for osteoporosis. Now our guys, the bodybuilding guys, the wrestlers, they do a mixture of testosterone, and you think, oh, they're going to have big bones, right? Very difficult because they also have the steroids who are sucking the life out of the bones. You know, steroid therapy, bone weakening. So they are at that little gap where a lot of them get osteoporosis. So they are also in the future the patients in need for therapy if they survive the heart attack. So, and that is going to be very interesting. We also have a new clientele that nobody talks about. I'm an endocrinologist, so I know how hormones work. We have a new clientele that we have to focus on, and that is the big population of transgenders. So you are, when you are changing your sex, your genetics are still XX or XY. So, and we don't know anything about what is the later picture when we are switching the hormones, because women need estrogens and they have the receptors. Yes, a man with the XY is also getting estrogens to change. But do those receptors act the same way like a woman's receptor? Or are these people later on in danger to have severe osteoporosis? And most of the time this transition is done in younger age. We know that the bone peak mass is achieved when they are 26. So that is something that will be very, very interesting too, to follow those patients. And that is another pathway to open. Follow these patients to see how is it with your bone health.
I guess what Dr. Kasper-Bell is essentially highlighting, that beyond clinical setting, we will be actually lucky to potentially conduct research too, to just show some of the changes in a smaller patient population that we're yet to learn how the bone health is impacted by both genetics as well as environmental factors.
Fascinating. You have a question?
In Europe, where this is more commonly used, is it used as a screening tool, or is it also used to follow up treatment effectiveness?
I'll just repeat that question. So the question was, in Europe, where this tool is it used primarily as a screening tool, or is it also used to support treatment?
Both. And there is very good data out there. Yeah.
We have Chris with a question.
Are you going to be the only person trained on this, or do you have other people going with you?
Unfortunately, I'm the only one. Yeah.
Yeah, I think with the two of us being able to do the scans, it would be valuable just because we would like to utilize it as many days of the week as possible. So
I think so too, because it's an interdisciplinary project. You're sharing the patients. You want them as close to the team as possible. Like part of the reason, you're going out to a radiologist or a nuclear medicine specialist and you get a report that you can see on eHealth, and then you have to circle back to you guys. But keeping it within the project, I think, is smart. So we can pilot it.
Yeah, our plan is that we see those patients together.
Yeah.
So both of us are going to talk to them and discuss the treatment plan.
And partially because I think our patient population tends to be quite complex. From liver point of view, when I see my patients, I'm talking about liver-related symptoms as well as symptoms outside of liver, so including bone health. That's where Dr. Kasper-Bell's expertise come in, because she's well equipped to treat endocrine disorders, and osteoporosis fall under that. So for sure, I think that would be the initial stage, and it would be great to actually have a nursing support in the future, because then on the days when we have other commitment as clinicians, research day, education day, actually we could have somebody do the scan, so that we're utilizing.
That is down the road. The beginning is
the two of us.
In a research setting, however, when you're trying to get good data, having a single operator of the test decreases your intervariance between and bias.
That is correct.
So for a research study, having a single provider actually is a benefit.
So the good thing is that it is artificial intelligence driven. So the bias of interpreting is minimal. So that is good. We need more manpower to
and woman power.
To be able to make this after our project, when we can deliver our results, and it is suggestive for more support from provincial sides, that people are going to get on board. It always takes a long time to convince people, because you like to follow the old-fashioned way.
Mm-hmm. Well, thank you so much, both Dr. Niazi and Kasper-Bell. I mean, your commitment to this is clearly going to serve us for many years to come. So even though you're the winner of the 2024 Women Leading Philanthropy Grant, we're going to be seeing these patient ripples impact us for many years. So we're excited to have you back, and thank you so much for coming.
This group continues to engage and learn and grow. And if you feel inspired from tonight's stories, then we want you to share what you've learned with other people and help us grow our circle together.
So a quick reminder that we'll be announcing this year's shortlisted candidates, the grant proposals, very soon, so keep your eye on the inbox. And so these new ideas really represent the next wave of innovation driven by your generosity within this community. And mark your calendars for our next WLP voting meeting, which will take place on Monday, September 22nd, 2025.
And to those of our guests who are not Women Leading Philanthropy donors yet, we have someone at the registration desk ready to support, and Trisha's at the back there. And so you can help support this powerful program the way that it's delivered right here in Saskatchewan. So as the program tonight comes to a close, but the energy doesn't stop here, we invite you to mingle and continue to indulge in the desserts at the back and ask questions, be inspired, share your ideas, and if you'd like to renew your Women Leading Philanthropy membership, you can also stop by the registration desk with Tricia before you leave. So, welcome back or welcome to new friends, but we'll see you again in September. Thank you.
Thank you.